Okay, guys, very good morning, everyone, to you all. First of all, a big sorry to everyone. I didn't make classes and I didn't do the live sessions since a month, it seems. So, a big sorry. And so, how are you all? How are you all? How is your health? I hope each and everyone are doing very well. So, okay. See, I'm introducing myself. My name is M. Vijay Durga, and I am an orthopedics resident, and I have completed my MS orthopedics, and I completed my fellowship in obstetrics and gynecology. And each and everyone knows that since a month I'm uploading the classes regarding obstetrics and gynecology. Now, in nutshells, each and every topic I have uploaded, guys. Not only that, in orthopedics I have uploaded more than 60 videos, so please go through it. Each and every video is completely made out of the textbooks and all, and you can revise the entire chapter within 5 to 10 minutes. So make use of the classes and all. And not only orthopedics, and I have also uploaded the classes regarding the obstetrics and gynecology. And very briefly, and each and every video length is about more than half an hour. They are not more than 1 hour videos, so please make sure use of it. And not only that, please go through all the messages and comment section, message section, and post section, because I have uploaded the notes regarding each and every class, and also I have uploaded the corrections and all. So also thoroughly check those comments and check the posts for for the notes and all. And today I just want to uh, you know tell you about the oncology. So, in this live session, I'm going to tell about the oncology and gynecology. Okay, so gynec onco we are going to discuss. Now we are going to discuss about the oncology. So, hi everyone, how are you all? Now I'm starting the live session regarding oncology and gynecology. Okay, so please follow the class. Any doubts, please, write it in the comment section. I'm going to start about the oncology now. First of all, I'm going to show what I'm going to discuss now. So please have a look. Yeah, please have a look. This is what I'm going to talk about the entire live session in this live session. See, that is oncology and gynecology. So my motive is prevention is better than cure. So screening plays a very important role, and while diagnose and management and all treatment. So we are going to discuss about the vulval cancer, vaginal cancer, cervical cancer, uterine cancer, endometrial cancer, ovarian cancer, and fallopian tube cancer. So, in the subheadings, like we are going to discuss about the clinical features, investigations, management, prophylaxis, and palliative and adjuvant management, symptomatic management. Everything we will going to learn in this session. Okay. Good morning, everyone. Okay, first coming to the vulval cancer. See, guys, remember one thing. See, in developed countries, in developing countries, there is lots of difference between the, you know, cancer incidence and all. So, in developing countries, cervical cancer is increasing day by day, and it is unfortunate. I'm very sad to telling that carcinoma service is increasing rapidly, and especially in developing countries, it is all about 80%, 60 to 80%. And those are the those are the recording session. I mean, those are the recording data that is available, not accurate data. But what is the available data is up to 80% or 60% in developing countries. Carcinoma services, observed. Remaining all cancers are around 5% or 5 to 10%. So So please make sure that each and every one aware of the carcinoma cervix and screening procedures, cooperative screening procedures, and prophylaxis, vaccination, support the vaccination, and all everything. We have to keep it in our mind. This is the incidence of the overall cancers. So now I'm going to talking about the vulval cancer. So vulval cancer mostly seen in the early aged women, not only early aged women, it is also seen in middle aged women also. So vulval cancer presentation is mostly presenting with the tumor or a mass or the vulva. Okay, so remember that in anything, a cancer or a benign lesion. So first of all, always remember, if the lesion is benign or malignancy, we have to know. So all these things can be, diagnosed with the help of histopathological examinations. Okay, if the tumor is overgrowth or tumor is growing rapidly, then consider it might be a malignancy. So histopathological examination is always the gold standard and um, confirmatory test for any of the malignancy tumors. Okay, so vulval cancer always presented with the mass and all. So is there any discharge? And if the patient if the patient had any signs of weight loss, loss of appetite, these are the constitutional symptoms. Always remember, malignancy symptoms, like if the patient always observe clinical features, like if the patient had any sort of malignancy or any sort of cancer, it first shows the reduction in weight, loss of appetite. So these are the two main things we have to keep it in our mind. And not only that, other symptoms like pain. See whether the pain is loculating or local pain or any radiation pain. Okay, radiating pain or local pain, all these things we have to keep it in our mind. Or any lumps. So all over the body we have to keep it in our mind. How to recognize a cancer symptoms? These are the common cancer symptoms, and mostly the hair fall. So in cancer patients, the hair fall is rapid, and there is loss of weight, and there is uh, and loss of weight and loss of appetite. These three things we observe rapidly, and not only that, these are the things. So coming to the vulval cancer, so if there is a lesion, always take a punch biopsy, or take for a piece, for to send the pathological examination, confirm whether there is any malignancy changes. So always think, malignancy changes, we have to know the difference between a normal cell, a benign cell, or a malignant cell. How the cells will replicate and all, or uh, how the cell evolves and all these things, we have to keep it in our mind. A normal cell is normal size, and the number of cells should not be increased. The size of the cell should not be increased. So we have to keep it in our mind that cytoplasmic ratio and nucleus and cytoplasmic ratio should be normal. And in benign and neoplastic cells, there is an abnormal nucleus and cytoplasmic ratio. So in malignant cells, there is a chromatin in lumps. Okay, the lumps of chromatin, and there is now in normal cells euchromatin is there, but in malignant cells there is hyperchromatic, and the chromatin is clumps, okay. So these are the differences we have to keep it in our mind. So cellular structure get cell distorted. So all these things we have to keep it in our mind. So how to treat the vulval cancer? So always, if the lesion is less than 2 centimeters, go for an excision with wide margin of 3 centimeters. So always keep it in our mind. Recurrence is the worst thing. So while excision the tumor, we have to access while going. I mean, if you are going for a wide excision, just clear the tumor with 3 centimeter margin. Okay, and Not only that, we have to keep it in our mind, chemotherapy and radiotherapy are also, we have to keep it in our mind. You have to go for post surgical radiotherapy and all. This is about vulval cancer. See, staging is depends upon, see, just keep it in our mind, staging or in cancer, excuse me, in cancer staging is really important. And staging should be, according to the involvement. See, again, vulval involvement, how the tumor grows, how it extends, and size of the tumor. Based upon this, all these things, and metastasis, all these things, keep it in our mind. The staging is, the staging itself gives idea about the size of the tumor, extension of the tumor, is there any metastasis. Okay, all these things we have to keep it in our mind. And according to that, we will go for a management. So early stage lesions, we will go for a excisions. And uh, and later on we will go for radiotherapy and chemotherapy, all these things. So coming to the vaginal cancer mostly, it is presented with a decubitus ulcer, any discharge, pain, and all this pneumonia, bleeding, everything are the manifestations. So mostly the ulcer should be present, maybe present in the upper third of the posterior wall. So upper third of the posterior wall of the vagina, it may be present, the cancer of the vagina. So all this, how to manage a vaginal cancer, prophylactically, like, we have to we have to pack the vagina for, in order to prevent discharge. So in order to prevent discharge, pack the vagina and all. So not only that, see, for vaginal cancer, we will go for vaginectomy or vaginoplasty and all. If there is an extension into the cervix or uterus, then we have to go for the entire hysterectomy. So advanced based upon the stage and severity of the cancer, we will operate. This is about vagina. And coming to the uterus cancer. See, uterus coming to the uterus. So uterine cancer, choriocarcinoma cancer, sarcomatous changes. Sarcoma is the main problem, and this is the serious cancer of the uterus, and endometrial cancer and all. See, uh, always remember, coming to the endometrial cancer, first of all, endometrial hyperplasia, is it typical or atypical, we have to see. So in endometrial hyperplasia, generally we can, if it is less severe, I mean, uh, coming to the less hyperplasia, severe hyperplasia, if it is less, we can, we can deal with ocipils or progesterone, mdpa, lifelong therapy we can give. But if the endometrial hyperplasia can be turned into, malignancy, so then we will go for a hysterectomy with bilateral salpingo-oophorectomy. So so ultimately, we will go for the surgical management. And um, this is one sort of management. And coming to the uh, and then this is what endometrial cancer. And choriocarcinoma is also important, choriocarcinoma of the uterus. So choriocarcinoma of uterus, it is also important. It is observed in the pregnancy because of mole and all. So trophoblastic tumors, okay, choriocarcinoma, all these things. So in choriocarcinoma, what is the main treatment is the methotrexate 5 mg per 5 days we have to give. And we have to follow the HCG levels. HCG levels should be less than 1 micro, HCG should be less than 1. Okay, so in the urine, so thoroughly you have to follow up with the beta HCG. Okay, This is what in choriocarcinoma we will treat with methotrexate. So along with it, methotrexate, we can also add folinic acid. Okay, we can also add folinic acid to prevent the folic acid toxicity. So keep it in mind this. And yeah, the most other thing we have to discuss is the like we have to discuss about the carcinoma of cervix now. Carcinoma cervix is very important, guys, which is evolving. It's like a pandemic, epidemic, pandemic, whatnot. Cervix carcinoma cervix is increasing, especially in the developing countries. So please keep it in your mind. Screening should be important, and screening should be done starting the 21 years of the age of the women. And so screening mostly pap smear. So pap smear, how to do pap smear, how to check all these things, now I'm going to tell, guys. This is the pap kit. See, so the pap smear kit consists of the pap smear kit consists of, see, mainly a spatula and endocervical brush and one cotton swab. Okay, this is the pap smear kit, guys. People with symptoms like cervix inflammation, any discharge, pain, dyspareunia, all these things, they and discharge and all, they, and mostly pain, they come with all these symptoms. So how to do pap smear is, we have to insert the spatula, whether it through the speculum or direct, um, a speculum examination, or we can also do direct with using sims or cuscus speculum. And always keep in our mind, if it is a cervix, and we have to ectocervix, and this is the endocervix. So the spatula is like this, the wooden spatula. So we have to rotate this like this, 360 degrees we have to rotate it. Okay, and if you doubt is there any extension into the endocervix, then use endocervical brush. Okay, endocervical brush, just tip. See if it is a cervix, should see, tip. And you also know how the cervix appears. Cervix is very neat, clean, pinkish in color. And there is a different, the slit, if it is round and all, it is nulliparous, or wide, young cervix. And if it is a slit like, that is multiparous, or older cervix and all. Okay, endocervix and this. So how to make a smear? First, wooden spatula immediately, without after taking the swab and all, you have to put it in the slide of 2/3 of the slide. Use spatula and endocervical brush 1/3. Okay, again we shouldn't allow it to in the air dry, and you should keep it in a container with 99% ethyl alcohol, which is the staining. We have to keep it in the fluid at least for 1 hour, or at least for 30 to 40 minutes, 60 minutes, like that. And then if we check under the microscope, is there any dysplasia, we observed or noted how the cervix, how the cervicus has appears, and is there any dysplasia, whether it is mild, moderate, severe dysplasia, or intraepithelial, invasor, is there any invasion, or like that, we have to check it for that. See, squamous metaplasia is the malignancy we observed at the squamo-columnar junction of the cervix. Okay, this is about pap smear. See, two types of pap smear: liquid based cytology available, and smear based also we can do. In liquid based in a menthol solution, we use the brush and just discard the brush in the methanol solution, and we have to send for cytological examination and all. So this is about the screening. So coming to the so after 21 years, we can go for screening, we can go for follow-ups and all. And this is what about PAP. And I am going to tell about the prophylaxis. Carcinoma cervix, prophylaxis is the, like, HPV vaccine is available. You know, HPV vaccine is helps a lot to prevent carcinoma cervix up to 80% in younger women and also in older women. And HPV vaccine is not only prevents the carcinoma cervix, lower genital tract carcinomas. All the lower genital carcinomas are being prevented by the HPV vaccine. Okay, anal cancer, including anal cancer, vaginal cancer, vulval cancer, and cervical cancer. So lower genital, any any cancers are being prevented by the HPV vaccine. So the most notorious HPV virus is that 16 and 18 are the malignant strains. So bivalent is available, and quadrivalent is also available. Nanovalent is also available. So these are the tumor strain. These are the viral strains. Malignancy potential is most for 16-18. So 16-18 is the basic thing all the people are taking and all. Okay, okay, cervarix, which is a bivalent, but nanovalent it is much better, because nanovalent covers almost 9 HPV strains. Almost it covers all, all the almost all disease causing HPV disease causing malignancy potential, that virus strain it covers. So nanovalent is much better than quadria and cervarix. And so prevention is better than cure. Go for the HPV vaccine. So in adolescents or in adolescent age group people, there are three doses: 3, 1, and 6. And in adult patients, Gardasil will go for 0 to 6. These are the dosages. Okay, that is 1 ml IM shots. Okay, this is about carcinoma cervix. So carcinoma cervix, how to treat? See, there are lots of managements are available carcinoma cervix. So first of all, how to diagnosis with the call. First, if you observe any lesions or any abnormality of the cervix, just go for the estovate staining and all. If there is an any abnormal growth observed, then the cells are stained with estovate. If you want to use leukocytin, because of glycogen in present in the normal cells take iodine, it appears blue, and cancer cells won't take the iodine. So in that way we can detect the dysplasia of the carcinoma and all. See, immunocytology is available for pap and all. Whatever the malignancy should be confirmed by the biopsy ultimate. So how to treat? So simple treatment of carcinoma cervix, prevention with prophylaxis, HPV vaccine and all. After that, we will go for removal of the lesions and all. And in early stages, conjugation is a very important method. Conjugation, leap, and large leap techniques, um, cryo I mean cryosurgeries are important. While these are only OPD based treatments and very much useful, and almost they prevent the transformation into malignancy. So all these things are important. Cryosurgery is also important. It is very easy. The technique is the freeze technique. So they are like, what the content used in the cryosurgery is CO2, and CO2, freon and all. So mostly used is the and nitrous oxide, and mostly used is dioxide, it seems. Okay, mostly used one is the carbon dioxide at minus 60 degrees centigrade. In freeze the technique, we put that probe, uh, we put the cryosurgery probe in the lesion for 9 minutes. It can destroy up to 3 mm or 3 to 5 mm, 4 mm lesions up to depth. It can it can clear the lesion. Okay, so follow thoroughly follow for at least 6 months, 6 months follow up you have to do. And if there is a recurrence, go for conization. Conization is mostly for endocervical involvement. Okay, not only that, electrocoagulation is by leap. So all these things are managing. If the cancer is more severe or advanced, or anti-cervix is involved in involved in malignancy, then go for a trachelectomy. Trachelectomy is nothing but completely removal of the cervix. Okay, this is all about carcinoma cervix. And always remember in mind metastasis. If there is any mets to vagina or mets to, you know, any metastasis to uterus or surrounding structures, in a stage for any cancer, surrounding tissue, if it is involved, it get comes under this stage 4 or advanced stage. You know, bladder, rectum, perineum, omentum, and not only that, there is a distant mets also. So mets are mostly observed in ovarian cancer. So in ovarian cancer, up to lungs, bone, bowel, bladder, rectum, breast, everything, mets observed in the, even brain mets is observed in the ovarian cancer. So always keep in mind mets. So now till now I discuss about the carcinoma cervix. Okay, carcinoma cervix, endometrial cervix. See, always keep it in our minds. Endometrioma is a tumor. If it is a sarcoma, it is a severe tumor. See, actually, before the cervix, we discussed about endometriosis and uterus cancer also. But I want to tell one thing: endometrial cancers and uterine cancers, depends upon the surgical staging, debulking. Only stage one, stage two go for hysterectomies. With bilateral salpingo-oophorectomy, it is a prophylactic preventive measure generally followed in genetically predisposed or any previous family history like that. Prophylactically, go for oophorectomy also in uterine and endometrial cancers. So stage 1 and stage 2 are generally deal with hysterectomies. So Vatim's hysterectomy mostly will do. Say Vatim's hysterectomy, what it involves is we have to remove the parametrium, lymph nodes. So lymph node mets are also important. Mostly abdominal lymph nodes like parietic lymph nodes, pelvic lymph nodes, all these things are important. So endometriosis stage 3, stage 4 are non inoperable. So we started with chemotherapy, surgery, and post-operative chemotherapy, or radiotherapy, surgery, or post-operative radiotherapy, or we can go for three combination will go. But always remember, post-operative chemotherapy is won't work that much. So pre-operative chemotherapy helps in debulking of the tumor. It regresses the tumor. So we use mostly cisplatin. Cisplatin is the most important drug in oncology and gynecology. It uses mostly before the surgery. Not only in the surgery, it also helpful in therapeutic. It has its own therapeutic actions in treating the tumor and all. And not only that, post-operative chemotherapy we also not only pre-operative and therapeutic effects of cisplatin are very much important. After surgery, post-operative radiotherapy, we should keep it in our mind. Post-operative radiotherapy, so it prevents the it prevents the metastasis, or if there any lymph node mets are observed, it distracts the any mets or any, after surgery, if there is any other because of some tumor materials might be not dissected or completely removed. So post-operative radiotherapy helps in clearing that. So always keep it in your mind. The survival rate for stage 1, stage at only stage 1, stage 2, only the survival rate about 10 years of survival rate we can assure 90% of the people. But after stage 2, stage 3, stage 4, in every all cancers is very less chance of survival rate of 5 years. Okay, it's very less of only 20 to 30%. So we have to uh, just assure or educate the patient while dealing with all these problems. And this is what endometrial carcinoma, choriocarcinoma, methotrexate is the main thing, and cisplatin is the main thing. Preoperatively and therapeutically, cisplatin is very much important, and 5-FU is also helpful in vulval cancer. 5-fluorouracil is a is completely eradicate the vulvar tumors. Um, these are chemotherapy. Not only that, there are lots of chemotherapeutic drugs, vinblastine, vincristine, and bleomycin, cyclophosphamide, cyclizine, everything. Lots of drugs are there. And but most important drug is the cisplatin, 5-fluorouracil, doxorubicin, uh, and methotrexate. These are the four drugs, are the key drugs in treating the patient. And coming to the fallopian tube, not tuber, sorry, fallopian tube cancer. See, fallopian tube cancers are mostly presented with the discharge, watery discharge, and later it turns into amber colored discharges. So it might not be palpable because of the less size. So if you see any discharge with adnexal mass, you can consider it as a fallopian tube tumors. This is also like that. Bilateral salpingo-oophorectomy and hysterectomy we will do. Okay, and coming to the ovarian disorders, it is also some vast, not vast. Okay, we will discuss. See, ovarian disorders. See, ovaries, we are everyone and every female has the two ovaries. So ovaries, how the presenting, see whether it is malignancy or benign, sorry, benign tumors or malignant tumors. So most of the problem presented the women or female with the ovarian cyst. So cyst is the most problematic to cysts are the most problematic to most of the females. So how to deal with that? First of all, there are like functional cysts. Functional cysts are nothing but the cyst. If it is a more than 3 centimeters, then it is considered as a functional cyst. So how to deal with the functional cyst is we have to follow up for 6 months. If the cyst is greater than 7 centimeters, then it might be you know considered as malignant cyst. Okay, cyst can be vanished, or cysts can be disappear on its own, or cysts resolve on its own. Okay, if they are going, that is a problem. Laparoscopic cystectomy or mini labs, easily we can remove. Okay, but no drainage. Draining is little bit you know complicated procedure, because if it is a malignant or any spillage, so laparoscopic cystectomy is the best thing. And small cysts are resolved, and other type of cysts like lutein cysts and thecal cysts. Luteal cysts are nothing but corpus luteal cyst. On US sheet appears as a spider web. And thecal lutein cysts are due to choriocarcinoma or observed in the mole and all. Okay, like lutein cysts in associated with all this choriocarcinoma and all, it is observed. So these are about cyst. Now, okay. See, ossipils can decreases the size of the, helps in decreasing or reducing the size of the cyst. Okay. This is all about the cyst and all ovarian cyst. Now, Coming to the malignancy tumors. See, ovarian tumors are divided into epithelial tumors, germinal, or stromal tumors, or germ cell tumors. All these things. See, ovarian tumor classification is very much important and is easy. So keep it in your mind. And also, cis PCOS is important in PC. I forgot to say PCOS. In PCOS, multiple cis, more than 20 or 9 to 20 cis will be there, and they are about 1 centimeter. There is a polycystic ovarian syndrome. These are the cis. They can be treated with OCPs and all. Okay. Okay, these are about cis. And ovaries, coming to the ovaries, how they presented unilateral or bilateral presentation. Simply, ovarian tumors can be, go for a hysterectomy and with bilateral salpingo oophorectomy. Tumors like mucinous cyst, they are about 10 kgs. We can observe a large cyst or large tumors like, mucinous cyst, adenocarcinoma of ovary, and some ovarian tumors presented with, especially benign ovarian fibromas, are presented with ascites, Meek syndrome. We have to keep it in our mind. So what is the difference between ascites and ovarian tumors? Ovarian cyst. See, in ascites the belly grows laterally. In ovary the belly grows vertically. Okay. And this is what thing. Everything tumor excision, tumor staging, or surgical removal of the tumor is important. And surgical debulking of the tumor, ovarian tumors, are pretty much important because of the large size and advanced stages met. So there is an surgical staging is important. Debulking is very much important in grade 3, 4, or later stage 4. All these things, advanced stages, debulking is important with chemotherapy. Chemo, uh, chemotherapy. Okay, all these things we have to keep it in mind. See, after in later advanced stage, first we will go for radiotherapy. Then after regression of the tumor, we will go for the hysterectomy. Okay, like that we have to plan of ovarian tumor. And uh, all these things we have to keep in mind. These are about the ovaries and all. So actually, prophylactically, and ovarian tumors, if there is an suspicion of hereditary or genetic predisposition or previous family history, then support, like encouraging or supporting the prophylactic removal of the ovaries. Okay, these are about carcinomas in gynecology. So how to deal with the palliative management or prophylactic management of lower genital tract malignancies, and palliative treatment, how to support the patient, is everything important. See, always prevention is better than cure. If there is a dysplasia, go for conjugation. It prevents carcinoma of cervix. And HPV vaccine prevents the carcinoma cervix. Adding the progesterone in the early endometrial hyperplasia of 10 mg MDPA or norethosterone, all these things prevents the endometrial cancer. Okay, OC pills prevents the uterine cancer or ovarian cancer. Not only that, breast cancer. So OC pills are also helpful. All these things are, prevention is better than cure. Helpful in prevention is better than cure. And how to deal with the palliative management, or how to deal with the patient with other symptoms like pain, nutrition, and other symptomatic management, we will going to discuss now. See, first of all, before starting the chemotherapy, patient weight we have to record. Nutrition is very much important. So before the chemotherapy and after the chemotherapy, if there is an decrease of 10% as body weight, then there is a malnutrition observed. So daily calorie intake should be 2000 kilocalories per day, 2200, and daily water intake should be 1 to 2 liters. Why I'm insisting means, if there is a loss of appetite, one thing, and they if they take water, maybe there might be a vomiting sensation, and because of vomiting sometimes they want to take more water and all. So encourage or make a habit of to take, more than 1 to 2 liters, like more than 1 liter to 2 liter water. um, and nutrition is very much important. See, proteins, high protein diet we have to give. If the proteins are less than, uh, you know uh, if protein diet, we have to keep it in our mind. High protein diet we have to give. And coming to the pain, see, pain is the most notorious thing because of the met metastasis and all, pains, muscle spasms and all. So muscle spasm can be treated with diazepam of 3 mg OD or BD doses. Not only that, simple paracetamol of 1 gram can also, TID, can also alleviate the pain. And other drugs like opioids, like, morphine, diamorphine, can be used. Diamorphine is superior than the morphine because a less dosage, like 1 mg of diamorphine, is better than morphine. Okay, it also decreases the pain. Heroin subcutaneously also can give. If all these things, oral and subcutaneous or any injections, if they won't work, we also go for a spinal drugs. Okay, spinal analgesics we will give. Okay, this is all about pain and all. So coming to the bone pain. In bone pain, the most, useful pain meds are the non-steroidal anti-inflammatory drugs. So NSAIDs are the main drugs. So, like NSAIDs, like we use diclo, we use diclo and naproxen. So, all these are important in bone pain. And prophylactically, if you observe osteoporosis, go for a bisphosphonate therapy. So, bisphosphonate therapy, TID dose, every weekly we will give. But keep in mind, the bisphosphonates have its adverse effects of necrosis. Okay, mostly mandible necrosis and all. So that one we have to keep in mind. We'll go for bisphosphonates, or we also give calcium supplements. We can also give the calcium supplements. This is all about pain. And also we can treat the bowel and bladder pain. Okay, bowel and bladder pain can also we can treat. Uh, okay, and constipation with laxatives and all. So bowel and bladder pain can be treated with the oxybutynin. Okay, 5 mg and all. So all these things we can decrease. Bowel pain, rectal pain, all these things. Okay, if because of opioids, constipation is the adverse effect, we will add laxatives. So how to deal with the vomiting? So vomiting can be treated with uh, haloperidol, and not only haloperidol, metoclopramide, and haloperidol, metoclopramide, domperidone, and ondansetron. All these are the drugs used for vomiting. Okay, in order to treat the vomiting and all. See, because of radiotherapy also, people suffers from vomiting and all. See, if we add octreotide helps in decreasing the intestinal secretions. It helps in elevate both diarrhea and vomiting. Okay, this is all about the palliative management or supportive therapy for a cancer patients. Not only that, emotional support, psychological support is very much important emotional psychological support to the counselings, and uh, we have to give some strength, and through they by telling all the possible ways, and the positive things and all, make sure that the the patient mentality should be peaceful and all. Okay, psychological therapy will go. Okay, all this thing, this is the palliative treatment. Okay, now see some points regarding radiotherapy and chemotherapy I will tell. See guys, radiotherapy and chemotherapy are the parallel to surgical management. They have their own adverse effects and all. Recurrence is observed in both. Meds are observed in both, and but radiotherapy has its own adverse effects and it has its own use. Surgical management has its own effects and own you know adverse effects and own use. Mostly radiotherapy people, because there is adverse effects like anemia is observed, and there is an stenosis, vaginal stenosis, all these things are observed, and anemia is the most important adverse effect of the mm, radiation therapy. In surgery, might not be complete eradication, and recurrence is the problem in surgery. And not only that, like recovery is also very important. Post operative recovery is pretty much important. Okay, radiotherapy. See, in a brief thing, I just want to give an idea about the radiotherapy. See, there is an external source of the radiotherapy, internal source of radiotherapy. Internal source of radiotherapy is nothing but brachytherapy, and external source through the skin to mission, or skin to the contact. The radiation is like that. That is external beam radiotherapy. See, all radiotherapists keep it in mind while coming to the lower genital tract. Lower genital tract malignancy, all the malignancies, it should not be exceed more than 5,000 rads. Because if 5,000 rads or 5,000 to 8,000, it should not be, not more than that. Not more than that. Radiation therapy mostly used cobalt and all. Those are the things we used for radiations and all. And coming to the chemotherapy, cisplatin is important preoperatively and therapeutically. There are lots of regimens like MAC regimens, BEP regimens, vincristine, VC regimens. All this, there are lots of regimens are also available. So mostly cisplatin is the radiosensitizer. Before starting radiotherapy, we give cisplatin on the day of the surgery, before 1 hour like that. Okay. So cisplatin helps in, which is a chemotherapeutic drug, which is a radiosensitizer. But post-operative chemotherapy doesn't give that much good results. Okay. So preoperative chemotherapy is always helpful. This is about chemo and radiotherapy. Not only that, like immunomodulators are also used, like tumor necrosis factor antibodies, and carcinoma, like embryo carcinoma antibodies, CEA antibodies, anti-antibodies, anti-AFP antibodies, or lots of immunomodulators are also, we have to keep it in our mind. Stem cell therapies are in research. Stem cell therapies are also helpful. These are under trials and all. So today I just gave a brief explanation about the malignancies in gynecology, that is lower genital tract, including vulval, vaginal, cervix, uterus. Uterus comes under endometrial cancer, choreo cancers, sarcomas, everything, sarcomas, and ovarian tumors and fallopian tumors, along with palliative managements and all, prophylactic managements and all. And one thing we have to keep it in our mind, meds of breast is very important. Birat staging is important. See, always keep it in our mind. One more thing, endometrial if there is an endometrial hyperplasia or a previous management of endometrial hyperplasia in the management in the way of malignancy dealing, there is no use of HRT and don't prescribe HRT. For a previously treated malignant endometrial malignancy women. And coming to the breast, so breast mastalgia or any mass you observed, first of all go for a prophylactic mammography, sorry, screening. We will go for mammography. Mammography can be done, every woman of 40 years can be do, above 40 years, with any sort of doubtful lumps in the breast. So any sort of doubtful lumps in the breast, we will go for a mammography. So breast management is also important. I have also uploaded the how to examine self examination of the breast. I have uploaded the self examination of the breast in the author flash videos itself, um, 1 week or 2 weeks back. Please thoroughly go through the charts and all, how to examine the breast and all. Self examination of the breast is very much important. By seeing itself, if there is invisible lumps or you know any pain or the breast, mastalgia or any adherence, skin changes, is there any puckered skin or like PD orange skin, like like any hotness, redness, everything you observed, or nipple retraction, nipple discharges, these are easily we can observe just self examination. And I uploaded the breast self examination charts and all. Okay, mammography is also important in screening the breast cancer and all. Thanks a lot, everyone. Please, please subscribe and please support the channel Auto Flash videos, and please subscribe and follow the channel Auto Flash videos. Love you all. Thank you, everyone. And please also see all the you know all the previously uploaded videos. Please go through thoroughly, watch all those videos. And thank you, everyone. A very happy new year, and I hope and I wish each and everyone a happy new year, healthy and wealthy happy new year. Thank you all. Bye. Out of breath. Hmm. Please don't post uh, messages not related to the topic or a subject. Okay, you know, I just talked about the oncology and gynecology. Hi, Rajesh. Please don't post messages not related to the subject. Thanks a lot. Thanks a lot, everyone. Please go through all the videos in Autoflash videos. Please share and subscribe. Thank you.